total parenteral nutrition or TPN. TPN, total parenteral nutrition. Total means that all daily nutritional needs for a child or adolescent are in the TPN bag. P, parenteral means that the daily feedings are given to the child or adolescent through a vein. N, nutrition means all the protein, fats, carbohydrates, vitamins, minerals that are needed for growth and activities. Total parenteral nutrition. It is also known as parenteral nutrition. It is a form of nutrition support given completely via the bloodstream. It is also called central parenteral nutrition or hyperalimentation. The term hyperalimentation is misnomer because it incorrectly implies that nutrients are supplied in excess of needs. Parenteral nutrition is the most complex prescription drug preparation used for routine patient care. A single patient parenteral nutrition admixture contains macronutrients and micronutrients. Given this complexity, parenteral nutrition is classified among the high-alert medication, a term that describes a drug that puts a patient at risk for significant harm when used in adults. Enteral nutrition. Tube feeding is nutrition provided through the gastrointestinal tract via a tube, catheter, or surgical made hole into the GIT tract. Enteral nutrition. Tube feeding is nutrition provided through the gastrointestinal tract via a tube, catheter, or a surgical made hole into the GIT tract. It is the preferred method of feeding when patients are unable to eat enough calories on their own. Enteral access devices are feeding tube placed directly into the GIT tract to deliver nutrients as well as additional fluids, and often is a method for delivering medication. A nasoenteric tube means that the tube enters the nose and the end of it may be in the stomach, duodenum, or jejunum. Gastrostomy and jejunostomy tubes are inserted through the skin through a small incision on the upper abdominal wall. Short-term enteral nutrition is usually defined as use less than 4 weeks. Long-term enteral nutrition is defined as use for more than 4 weeks. Benefits of enteral nutrition. Absorption of nutrients by the portal system, maintains gut integrity, maintains gut-associated lymphoid tissue, may protect against the translocation of bacteria into systemic circulation. So, enteral nutrition promotes mucosal cell turnover, while parenteral nutrition promotes mucosal atrophy. Other benefits are related to preservation of immune activity. The presence of nutrients within the gut support intestinal cells that produce a variety of immune factors, in part explaining why enteral nutrition carry a lower risk of infectious complication than parenteral nutrition. Compared with enteral nutrition, parenteral nutrition has the following disadvantages. It causes more complication. It does not preserve gastrointestinal tract structure and function as well. It is more costly. Parenteral nutrition can sustain life when patients are unable to take sufficient nourishment via the GIT for prolonged period. However, parenteral nutrition is associated with significant risk and complications. Alternative methods of nourishing patients should be considered in every case. Nutrition assessment. According to the function of GIT tract. If it works, so enteral nutrition. If it doesn't work, so parenteral nutrition. It can be short-term or long term. Short term, peripheral parental nutrition until GIT function return, or long term or fluid restriction, so central parental nutrition until gastrointestinal function return. Parental nutrition infusion can be continuous for 24 hours per day, cyclic, running for a period of between 8 to 18 or 20 hours each day, or intermittent, so on some days only. TPN may be short-term or long-term nutritional therapy. Partial parental nutrition. It supplies only part of daily nutritional requirement, supplementing oral intake. Many hospitalized patients are given dextrose or amino acid solution by this method. Home parental nutrition. Home parental nutrition is feeding directly into the bloodstream at home. The feed is usually given through a long-term central venous catheter tunneled under the skin using a special pump. It requires learning specialized skill through an intensive training program and carefully following this program in a home setting. This training can be best provided by a group of health care specialists, including a physician, nurse, dietitians, psychiatrist, social worker, and pharmacist. Routes of TPN. Parental nutrition is administered by a peripheral or central venous catheter and termed peripheral parental nutrition or central parental nutrition. Central venous access. The main vein used for access to the central venous system are subclavian vein, internal and external jugular vein, cephalic and basilic veins, femoral veins. Central parental nutrition is usually hyperosmolar that can be infused safely into a large central vein with high flow rate. Concentrated central parental nutrition formula can provide increased calorie in a small volume. Nutritionally complete solution must be administered through a central venous catheter. Central veins are usually the veins of choice because there is less risk of thermophlebitis and vessel damage. No pain. Disadvantage: requires surgery, more risk of sepsis than peripheral parental nutrition, high risk of mechanical complication. Peripherally inserted central catheter. Benefits: access to central vein, can accommodate hypertonic fluids, lower risk of phlebitis than peripheral parental nutrition, easier to insert than central line. Peripheral TPN. Advantages: it does not require surgery, less risk of sepsis than central TPN, no risk of mechanical complications, simplify nursing care, reduce cost, shorten the time to initiating nutritional support. Disadvantages: high risk of thrombophlebitis, painful, the availability of suitable peripheral vein, does not provide full nutrition support, needs more fluid to provide more nutrition. Peripheral parental nutrition is not appropriate for long-term parental nutrition, patients who are intolerant to parental lipid infusion, fluid restricted, needs large amount of fluids. The relatively low nutrient content of peripheral parental nutrition makes this route more appropriate for preventing malnutrition than for correcting existing nutritional deficit. Patients with elevated nutrition requirements due to hypermetabolic illness and those who require fluid restriction are not suitable candidates. It is most useful as a bridge therapy during transition period when oral enteral intake is suboptimal or in circumstances that don't justify placing a central venous catheter. To a certain extent, this Philippites risk may be mitigated by other measures such as limiting the duration of peripheral parenteral nutrition, changing the catheter every 24 to 48 hours, administering lipid emulsion through the same vein or as a component of the parenteral nutrition admixture. Osmolarity limits. For peripheral access, 600 to 900 millismol per liter. For center, more than 1800 millismol per liter. Increased osmolarity limits allow for higher concentration of dextrose and amino acid delivered. TPN is not compatible with many types of IV solution or medication and must be administered by itself. TPN must be administered using AID or IV pump and require special IV filter tubing for the amino acid and lipid emulsion to reduce the risk of particles entering the patient. Filters should be used as follows. TPN solution without lipids, use 0.22 micron filter. TPN solution with lipid or 3-in-1, use 1.2 micron filter. Indications for use. When we have to use TPN, patient with paralyzed or non-functional GIT or congestion that require bowel rest, such as small bowel obstruction, ulcerative colitis or pancreatitis. Patient who have had nothing by mouth for 7 days or longer. Critically ill patient. Babies with an immature gastrointestinal system or congenital malformation. Patient with chronic or extreme malnutrition or chronic diarrhea or vomiting with a need for surgery or chemotherapy. Patient in hyperbolic state such as burn, sepsis or trauma. Composition of TPN or nutrition requirements. Macronutrients as protein, carbohydrate and lipids. Micronutrients as electrolyte, trace element, vitamins and water. Preparing TPN solution. We have two types. Solution with lipid or 3-in-1, solution without lipid or 2-in-1. First, 3-in-1 solution or total nutrient admixture. It is a complete parenteral nutrition formulation composed of all macronutrients, including dextrose, amino acid, and intravenous fat emulsion, in one bag. It is also called all-in-one or total nutrition admixture. Advantages of 3-in-1: lower cost of preparation, less administration time for nurses, potentially reduced risk of sepsis. Disadvantage of 3-in-1: precipitant cannot be seen due to presence of fat, not stable as long as TPN without lipids. Expiration date for 3-in-1 is 7 days. It remains at room temperature for 24 hours. 2-in-1 solution. It composed of dextrose and amino acid. Lipid administered separately to provide essential fatty acid. Expiration date for 2-in-1 is 21 days. Parenteral nutrition requirement for the adult patient. Parenteral nutrition requirement should always be calculated based on the individual needs of the patient. Variations in nutritional requirements are dependent on the patient's body weight, age, sex, activity and metabolic requirement. Assessment should be performed by staff trained in nutrition assessment. Basic adult daily requirements for total parental nutrition. Water, it needs 30 to 40 milli per kg body weight per day. Energy per kg body weight per day for medical patient 30 to 35 kilocalorie. Post-operative patient 30 to 45 kilocalorie. Hypercatabolic patients 45 kilocalories. Amino acid, medical patient 1 gram. Post-operative patient 2 gram. Special consideration. Patients who have renal insufficiency and are not receiving dialysis or who have liver failure require solution with reduced protein content and a high percentage of essential amino acids. For patients with heart or kidney failure, liquid intake must be limited. For patients with respiratory failure, a lipid emulsion must provide most of non-protein calories to minimize carbon dioxide production by carbohydrate metabolism. Neonates require lower dextrose concentration. Preparing TPN solution. Carbohydrate, dextrose, primary energy source, 3.4 kilocalorie per gram. Amount of carbohydrate in solution dependent upon caloric requirement. Optimal balance of carbohydrate and fat for non-protein calories. According to USP, dextrose are acidic with a pH ranging from 3.5 to 6.5. Higher dextrose concentration, greater than 10%, are generally reserved for central venous administration. Protein. 1 gram of protein gives 4 kilocalories. Standard solution provide essential and non-essential amino acids. Special formulas are available for patients with renal and hepatic dysfunction. Amino acids have high osmolarity, which limits their use in peripheral parental nutrition. The average nitrogen content of protein was found to be about 16%, which led to the use of calculation in times 6.25 to convert nitrogen content into protein content. Lipids. Concentrated source of calories. 1 gram of fat gives 9 kilocalories. 10% solution provides 1.1 kilocalorie per milliliter. 20% solution provides 2 kilocalories per milliliter. Lipids infused via peripheral parental nutrition may provide protection from phlebitis. Lipid emulsion appear to provide protection to the vein and allow tolerance of high osmolarity of infused. The use of fat emulsion as energy source has a few definite advantages of carbohydrate in that they have a much higher caloric value for comparable volumes, have a low osmolar load on the circulation and hence don't give rise to the diuresis, may be administered by peripheral route, enables the administration of fat-soluble vitamins, ensure avoidance of essential fatty acid deficiency. TPN formulation without lipid, or 2-in-1 solution. Calories from amino acid represent 20 to 25%. Calories from dextrose represent 75 to 80%. TPN formulation with lipid or 3-in-1 solution. Calories from amino acid 20 to 25%. Calories from lipids 20%. Calories from dextrose 55 to 60%. 1 gram protein gives 4 kilocalories. 1 gram of fat gives 9 kilocalories. 1 gram of dextrose gives 3.4 kilocalories. 6.25 gram protein gives 1 gram nitrogen. Electrolytes. Electrolytes perform vital physiological functions, giving them an essential place in all parental nutrition formulation. The electrolyte content of the parental nutrition prescription is adjusted on the basis of the patient's clinical status, laboratory results, acid-base balance, and medication profile. Parental nutrition recipients are especially prone to electrolyte disturbance. Gastrointestinal disorders, severe enough to require parental nutrition, are often associated with high losses of fluid and electrolyte through diarrhea, fistula output, or gastric drainage. Renal insufficiency may require a reduction in the electrolyte dose, particularly with regard to the potassium and phosphorus content of the formulation. Electrolyte product used in parental nutrition formulation contain no sodium bicarbonate because of the risk of forming precipitate with other electrolyte. Instead, parental nutrition formulation contain acetate salts that are converted by the liver to bicarbonate. Both sodium and potassium can be added to parental nutrition formulation as either the colloid or acetate salt. This choice allows the parental nutrition to be balanced according to the acid-base requirement. Daily electrolyte requirement: sodium 1 to 2 milliequivalent per kg, chloride as needed to maintain acid-base balance, acetate as needed to maintain acid-base balance, calcium 10 to 15 milliequivalent, magnesium 8 to 20 milliequivalent, phosphate 20 to 40 millimole. Trace elements added to TPN. Trace minerals are elements that act as cofactors for enzymes or assist in the transport of substance across cell membranes. Parental nutrition formulation supply chromium, copper, manganese, and zinc. Long-term parental nutrition recipients receive selenium to avoid the risk of cardiomyopathy associated with a deficiency of this mineral. Selenium supplementation is also associated with improved outcomes in the critically ill who receive parental nutrition. Iron is an essential trace mineral. The potential for iron overload and concern about the stability of iron in parental nutrition formulation prevent routine administration of iron to parental nutrition recipient. Instead, patients with evidence of iron deficiency receive supplementation with an intravenous iron product as a separate infusion. At present, parenteral trace mineral products contain no iodine because in the past sufficient cutaneous absorption of the element occurred with the use of iodine-based skin disinfectant for central line care. The shift to chlorhexidine disinfectant may lead to a need to supplement iodine in parental nutrition formulation as well. Illness and organ function have an impact on trace mineral requirement. Patients experiencing excessive gastrointestinal losses from diarrhea, ileostomy, or fistula output may require additional zinc. Liver disease, on the other hand, impairs excretion of copper and manganese, leaving patients vulnerable to toxicity. Long-term parental nutrition recipients are especially at risk for developing trace mineral abnormalities. Reports of Parkinsonian-like symptoms due to manganese toxicity have appeared in the literature. Vitamins added to the TPN to provide the needed daily amount of vitamins. It is the vitamins that are added to the TPN mixture that turn it yellow. Fluid requirements. Fluid requirements increased in some cases as in fever, fistula, diarrhea, nasogastric suction, or decreased in cases like renal failure, congestive heart failure, cirrhotic ascites, pulmonary diseases. Glycemic control. The level of sugar should be adjusted. Insulin added to prevent hyperglycemia induced by high carbohydrate load. Up to 10% of insulin added to parental nutrition solution may adsorb to the IV bag. Advantage: tight control of blood glucose improve outcome and reduce infection, prevent consumption of protein as energy source. Mixing TPN. Phosphates injected first. Add amino acid, dextrose, lipid and water. Then add the other electrolyte. Phosphate must be separated from calcium and magnesium. TPN must be inspected after mixing to look for precipitate. Components of daily energy expenditure. Basal energy expenditure. It is the energy used for normal body function when well awake in a thermoneutral environment and in a basal fasting state after overnight bed rest. On average, it equals 20 kilocalories per kg per day. In cases of stress level, normal or mild stress level, 20 to 25 kilocalories per kg per day. In case of moderate stress level, 25 to 30 kilocalories per kg per day. In case of severe stress level, 30 to 40 kilocalories per kg per day. Pregnant woman in second or third trimester, add an additional 300 kilocalories per day. Herzberg equation. It is used for calculating total energy expenditure. First, we have to calculate basal energy expenditures and then determine activity or injury factors or stress factor, and then calculate total energy expenditure. Assessment of nutritional status or caloric requirement. Use Herzberg equation for calculating resting energy expenditure or basal energy expenditure. Total energy expenditure kilocalories per day equal to basal energy expenditure times stress factor and activity factor. Stress factor like surgery or infection equal to 1.2, trauma 1.5, sepsis 1.6, burns 1.622. Activity factor sedentary 1.2, normal activity 1.3, active 1.4, very active 1.5. Problems associated with parenteral nutrition. It can be classified as the following: mechanical complication of insertion as pneumothorax, artery injury, air embolism, catheter tip misplacement, breakage and embolization, perforation. Later complication as thrombosis, displacement, breakage. Metabolic, nutritional deficiency or toxicity due to improper infusion as essential fatty acid. Hyper or hypoglycemia, hyperosmolarity, carbon dioxide retention. Azotemia, nitrogen in blood, hyperammonia, electrolyte imbalance, metabolic acidosis, hyperlipidemia, abnormal organ function. Infectious, castor site infection or castor-related sepsis, focal endocarditis, sepsis due to increased intestinal bacterial translocation. Catheter-related bloodstream infection. Catheter-related bloodstream infection, which starts at the hub connection, is the spread of bacteria through the bloodstream. There is an increased risk of catheter-related bloodstream infection with TPN due to the high dextrose concentration included. Localized infection at exit or enter site due to poor aseptic technique during insertion, care, or maintenance of center line or peripheral line. Pneumothorax. A pneumothorax occurs when the tip of the catheter enters the pleural space during insertion, causing the lung to collapse. Air embolism. An air embolism may occur if IV tubing disconnects and is open to air, or if part of catheter system is open or removed without being clamped. Hyperglycemia, related to sudden increase in glucose after recent malnourished state.
refeeding syndrome. In cases of severe weight loss or long-standing malnutrition, nutritional repletion can induce a condition known as refeeding syndrome. As nutrition is introduced, glucose stimulates an insulin response, which in turn promotes uptake of intracellular ions and a subsequent drop in serum concentration. Profound hypophosphatemia, the hallmark of refeeding syndrome, can be life-threatening if not detected and treated promptly. Low level of potassium and magnesium are also typical of the condition. Fluid overload due to the sodium retention is another common manifestation that can lead to pulmonary edema, heart failure, and dysrhythmia. Storage requirement for parenteral nutrition solution before and after addition. Parenteral nutrition solution, an ingredient used in compounding parenteral nutrition, should be stored at temperatures and conditions recommended by the manufacturer before compounding or additions have been made. After compounding, or if additions have been made, parenteral nutrition should be stored under refrigerated conditions until required by the patient, stored between 2 to 8 degrees centigrade. Lipid solution must not be frozen, as this can be fatal to patient. The lipid emulsion cracks and results in a fatal embolus. Expiry times of compounded parenteral nutrition and addition should be guided by information from the manufacturer regarding stability and compatibility and the clean room environment in which it is prepared. Before infusion, parenteral nutrition bag should be removed from fridge for about 1 to 2 hours before hanging. Light protection. Light and heat can influence chemical stability, e.g. vitamin A and E are light sensitive. Lipids undergo oxidation when exposed to light. Parenteral nutrition should be protected from light by using light protective cover available from the manufacturer. After hanging the bag, the bottom corners of the cover can be folded up and taped to the bag to prevent reflected light. Hang time. The maximum time for a solution bag to hang is 24 hours, and any remaining solution should be discarded. Stand-alone lipid emulsion hung separately have a maximum hang time of 12 hours. Compatibility with administrations. Non-PVC administration set should be used for delivery of solution containing fat emulsion. This is due to the extraction of phthalate plasticizer from PVC administration sets when exposed to fat. شكرا.